So much. Thanks, and everyone. Welcome, everyone. Welcome to the Nuts and Bolts of Advanced Care Planning. My name is Marlon John. You probably see right now it says Esther J. Lowe. That's Dr. Lowe's account I'm using because I had some issues trying to log on. So I want to apologize for that. But if you don't mind that, we should have a great session. And we're here to answer all your questions about advanced care planning. So each one of us will take a turn in terms of going over essentially the content, answer your questions. Because this is particularly at this time, this is a very important topic. So what I'll start doing is I'll just say a little bit about myself. Then I'll move to Dr. Lowe, and then Juanita can say a little bit about herself, and then we'll go into the agenda and move forward with the advanced directive and go into serious illness and those who are 85 plus. So that's essentially what we have in store for you. So again, my name is Marlon John. I work at Kaiser Permanente Santa Clara, and life care planning is one of the topics that I oversee in terms of programming for our health education department. I work with all of our educators who teach this class, which right now is particularly an important topic. We're getting a lot of people who have questions about advanced care planning. What happens if something were to occur to them and they weren't able to speak for themselves? So I help to support the information to help our educators with those classes. So with that said, I'll pass it on to Dr. Lowe, and then she'll introduce herself.
Hi, my name is Esther Lowe, Dr. Esther Lowe. I am a palliative care physician here at Kaiser Permanente at Santa Clara Medical Center. And I'm super, super excited to be here today and to be able to share this talk with my colleagues, Marlon and Juanita. And so thank you for coming. Juanita.
Hi, I'm Juanita Inderbitson, and I'm one of the managers here at Santa Clara Kaiser, and I oversee the life care planning program. So welcome everyone, and thank you for joining us today. I hope you find the information really valuable and take something away from it today.
Great. Awesome. So Dr. Lowe, if you don't mind sharing the slides, awesome. Thank you so much. And then if you have questions, you can feel free to drop them in the chat box, and then we'll take a look at them as we move through the program. I'm sure you may have a lot of questions. All of you are coming from different places in terms of your knowledge about advanced care planning. So feel free to drop them in the chat. What we'll do is we'll stop periodically to look at the chat to see if there's any questions, but we expect bulk of the questions to be answered at the Q&A. So what we're going to try to do is try to cover all the content we have within the next 30 minutes, and then open up the second half of the program just for your questions. So with that said, move to the next slide. So our objectives, essentially going over why plan, right? Advanced care planning. I'll talk about it, choosing a healthcare agent. We'll talk about the advanced care picking the healthcare directive, healthcare agent. Dr. Lowe will talk about serious illness and review the components of the physician's order for life-sustaining treatment. And then we'll end with questions. So that's what we have in store for you. And we move to the next slide. So just give me a second here. I'm going to move the chat boxes on my screen. So I'm just going to kind of move it out of the way here so I can go with that. All right. So I'm going to cover basically advanced care directives. So let's move to the next slide, Dr. Lowe. All right. In a perfect world, none of us would ever have a serious illness. All right. We'll always have great health. But what we've found out over the last several months is that the world is not so perfect. And things happen, right? Where maybe a loved one may have came down with a serious illness due to COVID or some other condition that left them unable to speak for themselves, right? So these things happen. And that's why advanced care planning is critically important. So what is advanced care planning? I guess the basic way to explain it essentially is preparing for future healthcare decisions. That's the essence of what advanced care planning is. And everyone at various stages within their lives will we approach with this topic. Hopefully we hope that you have a proactive approach about this, where you're basically actively documenting your healthcare wishes. So if you're in a situation where you're unable to speak for yourself, someone could do that for you, or there's orders laid down where physicians or medical staff will follow those orders. So that's essentially what advanced healthcare planning is. Next slide. So with the why should we complete an advanced healthcare directive? I think at the base of it, it essentially is to reduce the stress and confusion on family and loved ones. Oftentimes we won't do things for ourselves, but when we think of our loved ones, we certainly want to reduce the stress on them. Right. So take, for example, something will happen and somebody were in the hospital. Let's say, for example, you had your mother or something, serious illness happened where she was in the hospital, unable to speak for yourself. You can imagine she had children and extended family. Everyone shows up at the hospital and everyone has an idea of the care for that person. But if there's no documentation of it, then our physicians, the attendant physician has to make a decision, has to pick somebody who's going to make those healthcare decisions. And obviously that decision, the person they pick may have a different opinion about their mom's care versus someone else in the family. And that's where the stress happens. And that can really affect a lot of families, particularly at a time when everyone should come together to support that person. So this is essentially one of the most important parts of why you should complete an advanced healthcare directive, is to reduce the stress on your family if something were to happen. And provide direction. That's critical, right? You may have an idea of what you want, but if it's not documented, no one is going to know, because if you're in a situation where you can't speak for yourself, no one will know. And you and your family need to be clear about this. And then the last thing I would say about one of the reasons why is that oftentimes we think of advanced care planning for someone who is advanced age, maybe someone who's 80 years old or 90 years old. But things happen in life. We have many people who are 20 years old, 30 years old, who have serious illnesses where maybe you're walking across the street and you get hit by a car, right? And all of a sudden you're in the hospital and you're in a position where you can't speak for yourself, right? That would be an important document to have on hand so we know how we can follow your wishes. So those are the things I would say in terms of the reasons why you should complete an advanced healthcare directive. Next slide. Okay, choosing an agent. That is probably the most important part of the advanced directive. Actually the second most important part. The first part is actually document your wishes, but the second part is choosing an agent. What should your agent be able to do? Well, your agent, first of all, they have to acknowledge they want to be your agent, right? So maybe you are married and you think that maybe your spouse will want to be your agent. And if you approach that person, they may say, no, I don't necessarily want to be your agent, because being an agent can cause a lot of stress for a lot of people, because they have to make decisions in difficult moments. So basically, they need to be willing to be your agent, know the values that you have. For example, if you have a certain faith base, they need to know that and be able to follow those directions and be able to, and I mentioned this earlier, be able to make decisions during difficult times, because being in the hospital when somebody's not able to speak for themselves causes a lot of stress on families, and that person needs to make that decision and honor your wishes, right? You don't want them to essentially just make up things based on what they believe. You want them to make decisions based on what you believe. And again, reinforcing the fact that you should consider complete this document is that your wishes will be documented, and that's the only way legally we can do that, is completing the advanced directive. Next slide. So there are certain times when you complete this document when you may change it. All right. So if oftentimes when people fill out the document for the first time, it's essentially quite simple. It's really picking the agent, putting your personal information in there, and maybe indicating whether you want life-sustaining treatment or not, which Dr. Lowe will go over later, and a few other directives essentially of your care. That's essentially the base of it, and that's how I filled out my advanced directive. But what happens is there are times when you're going to change it, for example, for every decade. So maybe, because you can imagine when you grow between age 40 and 50, a lot of things will happen. And as you progress through life, things will happen where you may want to consider changing it, right? Someone died in the family, you may consider changing it. If you have a certain diagnosis, right, you want to change that. If your health declines, you may have a different opinion about the wishes you put in the directive. So one of the things I would share about the advanced directive is that, we go by the most recent one on file. And there's no timetable. So if you fill out one today and it's uploaded in your medical chart and you want to change it, say 2 weeks from now, because you changed your mind, you can actually do that. So there's no timetable in doing that, but you definitely want to consider times when you may want to change your wishes. Next slide. So this is essentially the Kaiser Permanente document here, which we essentially we kind of essentially go over. You have, I believe, the Santa Clara Library are going to send you documents, essentially links with basically California Advanced Directive and the Kaiser Permanente Advanced Healthcare Directive. Those both documents essentially the same. You can use the Kaiser Permanente document essentially anywhere, but if you feel more comfortable, you can actually fill out the California Advanced Healthcare Directive. I was going to kind of go over some of the most important parts of essentially the document. And later on, maybe I'll actually go into depth in terms of the what parts of the document are critically important. But most documents essentially starts off with the first page where you would essentially put your name and personal information, and then picking an agent. So listing the name of the person you want to make the healthcare decisions for you. So that's essentially commonly sometimes called, the durable power of attorney. Many people have that as part of their will. Designating somebody who will make healthcare decisions for you. Then after that, the form goes into things you want for yourself. For example, do you want life-sustaining treatment? And I just want to lightly touch on life-sustaining treatment. Essentially, is that things that will keep you comfortable, essentially, if you're in a position where you are not able to speak for yourself. Now, in most cases, that if the doctor decided that there's little hope that you will recover, it's important to know what you want. Because some people would not want to have life-sustaining treatment. They want nature to take its course, whereas some others may want to do that. But as you can see, that decision can put burden on a lot of families. So if you know what you want, you could document that. So that's essentially the third part of the document. And then it goes into, whether you want to essentially donate your body or not, or put, additional information in there in terms of restrictions on the healthcare agent. Because you can document in there that you can allow them to make decisions for you, healthcare decisions for you, even when you're able to speak. You can do that, or you could limit it that they can only make those decisions when you're in a position where you are not able to speak for yourself. So both documents are quite simple to fill out. If you don't know how to fill it out, you can always check in with a loved one to fill it out. Kaiser Permanente, we have a lot of classes that we actually go through each page of the document with you and give you more information about it. So that's essentially the bulk of essentially the advanced healthcare directive. Next slide. So the completing the advanced directive. So one of the things that if you first of all, you need to sign it, and then you have to have it notarized or witnessed. Now, those parts are critical. Signing is important because if you don't sign it, essentially it's not a legal document. Notarized, right now, obviously some notaries, used to have classes at Kaiser Permanente, we can have a notary therefore you can have it notarized, but because of COVID, we've suspended those services. But what I've found out is many banks and credit unions actually have notary services actually for free for their members. So that's one thing. If you download the document, you can fill it out depending on what state you live in, and actually take it to a bank and have it notarized there, and then submit it to your healthcare provider. Or you can have it witnessed. Now, witness is usually two witnesses. The first one is a family member. You can have a family member. The second one has to be someone who's not a family member, and they also have to sign saying that they're not related to you. So that's one of the common mistakes in a lot of the advanced directives that we receive at Kaiser Permanente, is that many times people have it filled out, but then they'll have two family members witness the document, and we have to send it back. And because it indicates that of what part of it that the second witness cannot be a family member. So make copies of it. You definitely want to do that. Talk to your agent about the wishes that you want, because if you just pick them as an agent and you have wishes in there that they may not agree with, they may not know about it. So it's important to let them know essentially your wishes. Let family members and close friends know about that. Another person is your doctor. Critical. Your doctor is important depending on your stage of life. You would want your doctor to actually know. At Kaiser Permanente, I think we do a great job with many of our physicians, including Dr. Lowe, who are well aware of our patients' wishes. Because the document is in the chart, and we can look at it and see what the wishes are of our patients. So it's a great document to have on file. Next slide. How do I get an advanced directive? So again, we, with the Santa Clara Library, we'll send you this information, but essentially you can get it from Kaiser Permanente, which is, kaiserpermanente.com/life care plan. There's also a lot of videos on there about life care planning that if you don't know much about it, you can learn more, but you can also download the document there. One of the great things about the Kaiser Permanente essentially document is that we have it in multiple languages. So we also have it in Spanish, Vietnamese, and also Chinese, Cantonese, I believe. So you can download that. Someone could fill it out. And then usually many places will, if you submit it, they'll have it translated because the doctors it must be in English for the doctors to read it. But obviously filling it out, most people feel comfortable filling it out in their own language. So that's one way we actually, what we do, they submit it in a different language. We send it to be translated to English, and then we upload it in the chart. You can go to California Healthcare Advanced Directive. So I give you that resource there. A great document, really easy to fill out. Make it legal, via the signature. That's critical, and also witness and notarize, as I mentioned earlier, and then submit it. That part, although it seems simple, a lot of people miss that part because oftentimes, it's not uncommon for us to talk to patients who've had the directive for several years without submitting it. And the challenge with that is that if you don't submit it, we don't know what your wishes are. As you can imagine, you can't predict what life will bring to you. So it's important that if you fill out the document, have it notarized, you went through all of that, you jumped over all those barriers, it's important to submit it to your healthcare provider. And if you feel you have questions or you're uncomfortable, you can always check with your medical provider. Many of our patients will reach out to our doctors to ask them questions about these. Sometimes they will meet with them via a one-on-one appointment with an educator to review some of the information on there. But it's essentially the critical part of it is to definitely submit it to your care provider. And the Kaiser Permanente, that's health education. You can do that as well. Next slide. All right. Well, that essentially my section of it kind of went through that really fast. It looks like we have about 8 minutes. I don't know if that's enough for you, Dr. Lowe, but we'll move it on to Dr. Lowe to talk about, advanced care planning with patients living with serious illness. Dr. Lowe?
Thank you, Marlon. I hope everybody can hear me. And so I'm going to take our conversation a step further. And now that, you've thought about who can speak for you, who that person is, I want to shift a little bit to think about if what yourself or your loved one is living with a serious illness and getting treatment, what does advanced care planning actually look like? So what I would like to do in the next few minutes to actually first share about the survey that was done in 2019 on asking Californians what their experience is with serious illness and end-of-life care. And then I'm going to talk a little bit in more detail about advanced care planning in someone with a serious illness and potentially what are the barriers that we see. And then lastly, focusing on the physician order for life-sustaining treatment. Short is for POLST. And how do we fill that out and when is it appropriate to do that? So in 2019, the California Healthcare Foundation commissioned a statewide survey and to really better understand the type of medical care and services Californians would prefer if they were to have a serious illness or if they were approaching end of life, and to explore the experiences of those who actually was dealing with these issues themselves or their loved ones. And this was published in what's called Help Wanted, Californians' Views and Experiences of Serious Illness and End-of-Life Care. So one of the questions asked, have you ever heard of any of these terms? And the number of people that responded was over 2,500. And you can see that in this graph, that majority of people have heard about hospice and what a do not resuscitate order and about 50% are aware of what advanced directive is. But very few people were aware about palliative care, and even less were aware about the physician order for life-sustaining treatment, which we'll talk about today. But however, in general, as compared to 2011, when the survey was originally conducted, there's definitely is an improvement in understanding all of these terminologies. Another question that the survey asked is, how important is each of these following to you at the end of life? The survey respondents reported that at the end of life, it would be extremely important to them and that their families are not burdened by the cost of treatment. This is 70% of the respondents, followed by making tough decisions about their case, which is 60%, or needing to take care of them, which is right up there, is 59%. I think what people don't realize that in order to not burden their families by tough decisions, it is paramount to share their care preferences ahead of time, before a time of medical crisis, and definitely before someone is at their end of life. Advanced care planning provides this opportunity to do exactly this, right? So I think our society urgently needs to have a paradigm shift in thinking about the role of advanced care planning. It really needs to move away from end of life care planning to care preferences planning when someone is getting active treatment, or actually it should actually start, like Marvin just mentioned, when we're healthy. Okay, that's where it should actually start. So this way it will result in better preparing the patient and their loved ones with receiving the type of care that they want at the end of life. And I think hopefully with lessening the burden, whether this is financial, this is emotional, mental, of the family members. This next slide, again, is based on the survey, and the survey question asked, if you did have an advanced illness, which would you prefer? Would you prefer to have dying a natural death if my heart would stop beating or if I would stop breathing? Or your preference is doctors and nurses using everything available to attempt to prolong my life, or I'm not sure. And you can see that there's some variations based on ethnicity as well as financial status, but that overall, the majority of the respondents say that they would prefer to die a natural death, 63%, rather than have doctors attempt everything to prolong their life, which is 9%. More than 1 in 4, which is about 28%, actually were not sure. Okay, they were actually not sure what they wanted. This next question from the survey asked, do you have any of your wishes regarding the medical treatment that you would want in a written document? And we can see that 2/3 of respondents for this particular survey said no. And those who were Latino, Black, and less financially well off are more likely to say no. 1/3 of respondents said yes. Those who are typically older, white, had a serious illness, and financially more well off are more likely to say yes based on this particular survey. I also find this to be very fascinating when the survey asked respondents who actually lost a loved one within the last 2 years about whether they were aware of their loved one's choice of place of death. And you can see based on this graph that there's a significant discrepancy between someone's preference of the place of death and the actual location of death. Even though 65% said that their loved ones would have preferred to die at home, you can see on this graph that only 39% actually had a death at the home. And even though the majority of the surveys, also if you look at those who prefer not to die in the hospital, majority of the people prefer not to die in the hospital, but yet almost 5 times that actually died in the hospital. I actually want to give a real case scenario that I've had in the clinic just several weeks ago to illustrate this. Is of a patient who I was seeing for consultation in our outpatient palliative care clinic. She's in her 60s, had a cancer called neuroendocrine cancer. That was overall very slow growing until most recently when the cancer became more aggressive and it spread to her liver. She was having a lot of symptoms of swelling in her legs and pain. The patient was very clear that she is not ready to give up on treatment, despite her oncologist's warning that her prognosis is limited and that even with treatment, the success rate is low. The patient made the decision to pursue treatment. At the same time, she told me that, Dr. Lowe, one of my greatest fears and what I don't want is actually die in the hospital, especially during this COVID pandemic. The husband was definitely concerned about his wife's health and wanted to support her the best way he can in her decision. So you can see that we have a patient who is dying from her cancer with months left to live, who despite the odds wanted to still try any treatment that is available. And I think in this context, her chance of dying at home is small. She received home health services who were visiting her, the nurse and physical therapy, our outpatient palliative care team assisted in managing her pain and helping translate her medical wishes into writing. It was actually something she was very reluctant to do earlier on in her cancer diagnosis. However, one day she was found to be confused, her blood pressure was low, and I think she really debated about coming in to the hospital, but ultimately made the decision to come in to the hospital, and she died. She died during that hospitalization. So I wanted to share this case because I think I wanted to highlight the challenge of actually honoring our loved ones' wishes, and even though that's something that they may want. So in patients with serious illness, I want us to think about advanced care planning really as a dynamic, ongoing process. It's not a one-size-fits-all. It's not a one-time conversation. It really focuses on trying to elicit the patient's values, what matters most, right? What matters most to our loved ones? What are their goals with treatment? What are they hoping for? Rather than focusing on any specific outcomes that limits the care or any specific interventions. And I also think that advanced care planning in someone living with a serious illness needs to really expand beyond end-of-life care planning, way more upstream when someone is actually starting their treatment, to share with their doctors and their loved ones what their care preferences are. And then lastly, this conversation, I think Marlon mentioned this earlier as well, really is best done outside of an acute hospital setting where everybody is stressed because their loved one isn't doing well. So even though I think we all know that this is important to do, just in the survey that I shared earlier, you can see that 2/3 of participants in that survey have not put their wishes in writing, and clearly there are barriers, right? So I've listed 4 buckets of barriers. The first one is patient-related barriers, and oftentimes what we've learned, and this is based on studies, published studies, is that patients oftentimes they wait for the physician. They wait for the physician to initiate the discussion. There's a sense of fear, sometimes a worry that if the patient themselves started this discussion, it will somehow burden their family or friends. Sometimes patients think that the physicians are way too busy. Yeah, they're way too busy, and that advance directive is actually a very private matter within the family. Sometimes there's just absolutely a lack of interest in this topic, or lack of knowledge on what advanced care planning is. And there's obviously also health literacy issues, and sometimes patients don't have a reliable proxy that they can actually appoint as a healthcare decision maker. So those are patient-related barriers. Some of the physician-related barriers based on studies have shown that sometimes physicians themselves actually lack a good understanding about the role of advanced directives or advanced care planning, or actually when to best have these discussions. Sometimes physicians are afraid that they would dampen the hope of patients and make them more depressed, so therefore they avoid having the conversation. Some physicians may actually be uncomfortable initiating this topic. And then there is sometimes physicians will say that, mention that because of their lack of time, because this type of discussion definitely takes time, you cannot rush through it as well. And sometimes physicians will actually wait for the patients to actually initiate. So these are the physician barriers. The cultural related barriers are related to communication preferences, that we know that in certain cultures, the patient themselves may not want to know all the details of their medical care, and they would actually prefer that to be given to their loved one, who then becomes their medical decision maker to help them with the decisions. And then in many cultures, talking openly about life, living, dying is very much a taboo subject. And so then therefore is not discussed. The last barrier that I talk about here is the documentation or implementation. What I mean by that is you have the documentation, is making sure that it makes it into your medical record. Like Marlon mentioned, I definitely have known many patients who they've done it years ago, part of the, with the lawyer, with the trust, but it's somewhere else and it never made it to the medical record. And then the other is once makes it to the medical record, making sure that all your healthcare providers are able to access it. Luckily here at Kaiser Permanente, we have an electronic healthcare record that expands across the continuum, whether you're getting care at home by your primary care physician, in the emergency room, in the hospital, or even out, you know, if you're getting home health services, we all have access to that record to see what your wishes are. Dr. Tenno published this, this was some time ago in a journal, mentioning that it's actually more than these barriers, that sometimes patients are not considered hopelessly ill, and sometimes patients, families, or even physicians don't think that they're that ill, so that the actual advance directive or written document never seemed to be applicable. And so therefore the transition to having a goals of care conversation actually never occurs, because nobody thought the patient was that sick to actually need the conversation. And family members or the person you designate, sometimes they were not available to talk to the care team. They were ineffectual or simply overwhelmed. Sometimes our family members who are decision makers are also our caregivers, and they are overwhelmed. And so it's hard for them to be in a place to make these important decisions. And then we also find that the content of the advance directive sometimes are very vague. And so, you know, I've read some of the advance directive that said, well, if I'm in a vegetative state, and or if I'm in a coma, or if, you know, so these statements sometimes are very vague. What you may think of vegetative state or being a vegetable may be very different than what another person would. So then it sometimes seems that the vagueness of it makes it not applicable in a clinical medical situation. Just really quickly here at KP, if you are a member with us, we call life care, you know, advanced care planning here at KP is called life care planning. And we have two primary components. The first is what Marlon talked about, is those who are healthy or they're in stable health. It's focusing on, well, gosh, who would speak for you if something unforeseen happened? And hopefully you can identify who that spokesperson is and translate it into a written document called Advance Directive for Healthcare. And the second component of our life care planning is focused on patients with a serious illness or those who are more older. And here, in terms of you're 85 and over, we think that that is a good time to talk to your loved ones about what's most important. So if you fall in one of those categories, and if you're a Kaiser member, I do encourage you to ask your primary care physician or any of the physicians to refer you, where we have trained medical clinicians who actually will meet. Right now, a lot of it is done via video or telephone to really then have a more in-depth discussion. And after that in-depth discussion, the result can be translated to a written document. All right, I'm going to shift, and this is the last part of my presentation, is talking about the physician order for life-sustaining treatment. You might have heard the terminology called POLST. I want to give a little bit of a historical context, how this all started. So in 1991, a medical ethicist in Oregon actually discovered that patients' preferences for end of life were not consistently honored. And recognize that the traditional advance directive were inadequate really for patients living with a serious illness or living with frailty who oftentimes required frequent emergency medical care. And so a group of stakeholders developed this tool to honor patients' wishes. And so this ultimately became known as the POLST. There's a national POLST advisory panel that was developed in 2004 to really establish quality standards and actually to help spread this throughout the 50 states. So let's go into what it actually is. So some of you may have seen this. In real life, the form is even more of a hot pink color because this is for first responders. So for patients with serious illness or over 85 and over, it is appropriate to actually consider translating your medical wishes into the POLST. And for people who are very clear that if they have died, they do not want the medical provider to attempt CPR, or they have very specific wishes about mechanical ventilation. That's a fancy word for the breathing tube down the windpipe. Then it's also appropriate for you to actually complete this documentation. So when to complete it? So if a patient or a decision maker is very clear when you're having the life portion of the conversation, especially for our Kaiser members, and it was found that patient again is not interested anymore to return to the hospital, or they didn't want to have CPR or the breathing tube called the mechanical ventilation, then it would be very appropriate to translate these wishes into the physician order for life-sustaining treatment document. So now I'm going to go into the nitty-gritty of, there were three main components, and I'm going to quickly go through these. So the first section is called the cardiopulmonary resuscitation. I know it's a mouthful. Short is for CPR. And the way I think about it is heart, lung resuscitation. And so this can be done both within if you're hospitalized and outside of the hospital. I think a common misconception that I've heard from patients is that if they check the box for do not attempt resuscitation but allow a natural death, then will my doctor stop treating me? So the short answer is no, absolutely not. Your doctors will continue to provide the best care to treat you, even if you are not interested in attempting CPR. Many people also think that CPR is more successful than it actually is, because they see it on TV, right? Or on Grey's Anatomy, for example. The success rate of attempting CPR is around 17% or so if it's actually done in the hospital setting. If it's done outside the hospital setting, it's oftentimes less than 10%. And for patients with a serious illness who are frail with advanced illness, it's oftentimes much less success rate than that. Okay, moving on to section B, which is really now focused on medical interventions. And so an example would be if someone they have a pulse, they're breathing, but they were in some type of a distress, for example, or they fainted, how would you like to be treated? And the three, I know the font of this is a little bit small, so I would say that it ranges anywhere from full treatment, which include really what many would consider aggressive care, including the breathing tube that goes down the windpipe, being in the intensive care unit to receive treatment, to do anything the doctors can do to keep the patient alive, to the second option, which is selective treatment, really is focusing on treating medical conditions while avoiding any burdensome measures. So in this particular category, coming into the hospital, getting IV fluids or IV antibiotics will fit in this particular category. And usually the type of care is provided in the hospital in like a regular hospital setting outside of the intensive care unit. And then lastly, there is the comfort-focused treatment. And this includes treating pain, treating shortness of breath with oxygen through the nose. And it's usually done outside of the hospital, in the home, in a residential care home, or in a nursing home facility. The last section is part C, is about artificially administered nutrition. So this is talking about a feeding tube. And I would say my experience is that most people have very strong feelings about whether they want a feeding tube and whether they want it temporarily or not at all, or for long term. Okay, so those are the three choices. Now, I usually suggest to patients and families that if they were not quite sure or they think they may, you may consider putting in trial of, and at the time can have more of a robust discussion, okay? All right, so this, I wanna just have a pictorial view to have everyone understand that if you choose to attempt heart-lung resuscitation, right, the cardiac pulmonary resuscitation called CPR, then on section B, you would select the full treatment. If in part A, you select and decide to have a natural death and forego attempting the heart-lung resuscitation, then in part B, you can select full treatment or selective treatment or comfort-focused treatment. So I want to show this because oftentimes this does make it a little bit confusing for people as they're filling it out. Okay, the last three slides, I'm going to focus on commonly asked questions. So one of the questions people ask is the POLST required by law? And so the answer is entirely voluntary. Here in California, the law does require healthcare providers to actually follow the physician order if a POLST has been completed. Another question is who would benefit from completing the POLST? We talked about this earlier in the presentation. So anyone who's seriously ill, very poor health, regardless of their age, it's appropriate to complete. And does the POLST replace the traditional advanced directive, right? Marlon talked about the advanced directive. So if you've done one, does that replace it? So it does not. It actually complements the advanced directive and does not replace it. And because the advanced directive is still necessary for you to appoint who your healthcare decision maker is. If someone had a POLST and an advanced directive that conflicted, which actually takes precedence, this does happen, right? You did an advanced directive, say several years ago, and you said something and then you complete a POLST maybe last month, then what if the two was in conflict? So if there's a conflict between any of your written documentation, the most recent documentation will be followed, okay? And who completes the POLST? So any healthcare professional can, usually this is a doctor, a nurse, a social worker, can help complete the form after the discussion with the patient and decision maker about his or her wishes and the goals of care. And both the doctor and the patient must sign the POLST in order for it to be valid, okay? All right. Another question is, I just also want to emphasize the POLST is really for outside of the hospital for our first responders. So oftentimes we'll say when you've completed it, put in a visible place. We usually say, you know, on the refrigerator door, so the first responders can see that. Let's see, I think this is the last slide. So if my loved one is no longer able to communicate, who can do it? So it can be done by a family member who understands their wishes. And once it's signed, you keep the original in a visible place, and a copy should be given to your healthcare provider so it goes into your medical record. And if you don't have a POLST, then what happens? Well, the emergency medical responders will not know your wishes, and the default here in California is to assume that you would want to attempt resuscitation and any of the life-saving measures. Okay, Marlon, do you want to conclude, or you want to continue with the conclusion?
You can conclude, and then we can just go right into questions. I think we have two questions in the chat.
Okay, so really the conclusions is, if you're to take away, is that it's a process for life care planning. It really is important to talk to your loved ones about what matters most. I know that both Marlon and myself focus on two particular documentation, but I have to say the documents are only as good as the conversation that comes before it. Choose your healthcare agent, right? Someone that will honor your wishes, and then translate this in completing the advance directive for healthcare, regardless of your health status. And so do it today. And those living with a serious illness can also consider completing the physician order for life-sustaining treatment document. Here are some resources as you're wondering where you can learn more about the POLST. Marlon talked about the California Advance Directive, and then also here the Kaiser Permanente version of the Advance Directive. Okay, I will stop there.
Okay, I think we have several questions now in the chat starting to build up, so we can kind of go through them, Dr. Lowe. I think the first one was, does one have to witness the document even when it's notarized? So I can take that one, Dr. Lowe.
Okay.
If you have it witnessed, you don't necessarily have, you don't have to have it notarized. Actually, it's one or the other. So you can have it witnessed or notarized. If you have it notarized, you don't have to have it witnessed. Second question, Dr. Lowe, you may get to take this one. If the recent diagnosis is the beginning stage of dementia, is creating an advance directive now still legal? Is it the person right mind, etc.?
Yes, that's a really good question. So
very good question.
So dementia there's various stages. In the early stages of dementia, many patients are still able to share with the family and their healthcare providers who they would want to appoint their healthcare agent. So if they are able to do that, I highly recommend translating that into an advance directive for healthcare. And here at Kaiser Permanente, in our senior health department, we have two fantastic social workers that can actually meet with patients and families to have that more in-depth conversation, especially when the patient are still able to share about their values and their goals.
Next question is, if you have a durable power of attorney, do you still need an advance directive? And I think there's the second part of the question, CPR success rates, are those for a certain age or all ages? So Dr. Lowe, I'll take that first part of that question with the durable power of attorney. So we can accept a durable power of attorney for healthcare. So that I'm going to emphasize that it must say for healthcare, because if it's for financial matters, then we can't accept that. So, but if you have a durable power of attorney for healthcare, you can submit that, and you don't have to fill out an advance directive. And Dr. Lowe, you want to take the second part of that question? CPR success rates, are those for certain age groups or all ages?
Let me unmute myself. Yes, great question. So the data for CPR comes from the National CPR Registry data, and so it's actually all comers. So these are all adults who have had CPR performed, and they looked at, in general, what the success rate is. And when they took a closer look, they found that those who were healthy or had a specific heart rhythm issue, they responded the best to attempting CPR. But those who had advancing illness, who were more frail in nature or older, did not do as well. And also what's also interesting is when they looked at the success rate of CPR done outside of the hospital, just like real estate, location mattered. And it was very interesting in cities where it was performed, there was a higher rate of success compared to rural areas.
Great. Next question says, what if I'm traveling and I have an accident? So that's a really good question. And Dr. Lo, I can take the first part of it, and you can, if you want to chime in, feel free to. But what I encourage you, if you're a Kaiser Permanente member, what you can do is download a portable electronic medical record. You can do that online, and you can take that with you. Sometimes you can even go to, basically the Department of Release of Medical Records, and they can put it in a flash drive. You can take that with you if you're traveling somewhere and something happened. The physicians can actually access that document and see the advance directive on there. I do want to caution you, though, that if you're traveling, the advance directive is only good for the state, right? So if you fill out one in California, it only applies to the laws within California. So some of the things you may fill out on the advance directive, if that's not applicable to a certain other state, they're not going to follow that document. So just keep that in mind. Dr. Lo, is there anything you want to add to that?
The only thing I would add is, again, the importance of sharing your wishes to your loved ones, so that if you are in an accident and the doctors reaches out to your family, they can speak on your behalf and know what it is that's important to you.
Yeah, great. All right. Looks like the next question is, how can I get my questions answered about the nebulous nature of the question in the advance directive? And all right. Well, I think so. I take from that question is that it's a little somewhat confusing, or it's not very like specific. So what we do have at the Kaiser, we do have our life care planning classes where our facilitators can go over it. It's online. It's on the second, at the Santa Clara location. It's on the second Saturday of each month, where our facilitators actually go through that. You can also meet with one of our health educators one-on-one to kind of go over it. Also, your doctor, use your resources. You can reach out to your doctor, and they can give you more specific information about some of the questions on the document. Dr. Lo, anything you want to add?
I think I'm a little bit unclear. Are you referring, because in the advanced directive booklet, there is a middle section about, your values and your goals, and, what does a good day look like? What would make life not acceptable? And again, those could be considered nebulous questions. Those take some thinking, because if someone just asks you, what are your values? I think we all need to take some time to think through it. So, but it is helpful to start thinking about what matters most, right? When you're healthy, what matters most? When someone's sick, oftentimes I find that their priorities shifts. And so then it's important to ask, again, what now matters most? What am I hoping for treatment? What am I most worried about? And so this is really then the discussion that is with your family members. And here at KP, we do have the facilitator, like I mentioned earlier, that helps facilitate that kind of particular type of discussion.
Absolutely. And in some of the classes, when we ask that question, is really for you to reflect on your life, right? Because the answers to some of the nebulous questions kind of provide direction for you in terms of your wishes. You may realize that certain things are not important and certain things are important, and that information can help guide your agent in terms of your following your wishes. I think there was a question about is the advanced directive valid in other states? I think I touched on that earlier. Essentially, if you fill out a California advanced directive, it's good within California. Again, other states may honor it as long as it doesn't there's no conflicts with some of the laws of that state. All right, another question. I think we have maybe 1 minute left. The last question I think is, I think a question, not mine, was about how in a vegetative state was vague. I had that in mind, and I thought it was clear. I'm not a KP member. Does that make sense, Dr. Lo? Vegetative state, just elaborating on that.
Yeah, vegetative state. So, interesting, when I've had patients share with me vegetative state, and I asked them, can you help clarify what that means? There was a spectrum of answers from if I couldn't be independent and someone else had to care for me, for someone that was considered vegetative state, to if I couldn't talk to my loved ones or recognize them and someone had to feed me, that was a vegetative state. So there was a huge variation, because I think sometimes we throw out that term quite loosely. So my suggestion is if your loved one mentions that, or you're thinking about that, it's probably good to think further. Well, what do I actually mean by that? So yeah.
Yeah, absolutely. Well, it looks like we had time. Nevin, I'm not sure if you want us to continue or you want us to wrap it up here. Let us know.
I think you guys answered all the questions, and if you want to add those links to share them with the attendees, that would be great.
Okay.
If you have any links or to the forms, or to, for instance, those Kaiser classes you mentioned, those links might be helpful as well. Other than that, thank you so much. It was really great presentation. Yeah, thank you all.
All right. I put in the
Thank you,
Kaiser.
Esther. Thank you, Marlon. This is Dr. Rajput. We really appreciate your help, and this was an excellent lecture. I just want to thank all the library members who are attending the lecture. Please stay tuned. Our next lecture will be on menopause and urinary incontinence.
Yes.
And Nevin will be posting out when we have the more details about it.
Yes, it's going to be in October. Yes.
Great. Thank you, everyone.
Thanks, everyone.
Thanks.
And also, I am sharing a link to our webpage. If you like this presentation, if you want to see more, or if you have any comments, suggestions that we can make it better, please type your comments on this link. And thank you all, and have a nice day.
Okay. Bye-bye.
Bye.
Bye.